Hello, everyone. So, welcome to the first episode of the Mind Body Science podcast. Today, I had a conversation with Dr. Riccardo De Giorgi. Dr. Riccardo is a clinical lecturer at the University of Oxford's Department of Psychiatry and is senior psychiatric trainee with NHS Foundation Trust, and he is deeply engaged in both clinical practice and academic research with a special focus on treatment-resistant mood disorders. His work explores the role of immunological and metabolic factors in mental illness and the potential role for repurposing existing medications such as statins and GLP-1 receptor agonists to treat patients who don't respond to conventional therapies. Overall, Dr. Riccardo is a passionate educator in the field of psychiatry, and I think you will retrieve a lot of interesting insights from this conversation. We go through diverse topics, from understanding how we need to look at the body to also understand the brain, how everything is connected. We look at the role of these new drugs, these GLP-1 receptor agonists. Particularly, many of you might know them through the name Ozempic, which is a type of these medications, and how they can potentially be used in cases of psychiatric and neuropsychiatric disorders. Of course, there is a lot that needs to be researched, but in this conversation, Dr. Riccardo shows us the landscape of research that is going on right now, always focusing on this idea that to understand the brain, we need to understand the body. Dr. Riccardo also presents us with a picture of what we might hope in the future as we advance in science and become better at understanding all of these different mental disorders that cause a lot of suffering, and leaves us with the idea that we should be hopeful in the progress that we can make in this field, particularly by following an approach that is data-driven and open-minded. With that being said, let's start the conversation. Okay, guys, so welcome to the Mind Body Science podcast. Today I have a special guest, Dr. Riccardo De Giorgi. First of all, I would like to thank you for accepting this invitation, and I would like to ask you to introduce a little bit of your work, your research interests, and what drew you to them.
Yeah, thank you, Joe, for having me. So my name is Riccardo, as you are saying. I'm a medical doctor and I work as a clinical lecturer at the Department of Psychiatry at the University of Oxford. I have a particular interest in psychopharmacology and in the evidence-based treatment of mental illness. I particularly look at mood disorders, especially depression. And I'm interested in pharmacological treatments in general, but particularly my area of expertise has got to do with repurposing drugs, which is a bit of a fancy word to say looking at drugs that are already used in other fields of medicine, and they might play a role in the treatment of mental disorders as well. So we try to take these drugs and see if they can be repositioned for use in psychiatry. And what drove me to this specific area, I think I've just always been very interested at the interface between physical and mental health. And indeed, I maintain this is a bit of a false dichotomy that we should really overcome at this point. And I think my hope actually with doing work in this area is that I can give some contribution in this regard by linking these two aspects, the physical and the mental health aspects, a bit more by the means of common treatment.
Yeah, no, I definitely feel that these days, especially now that we are taking more of a systems approach to a lot of these conditions, it's important to always consider the body and the mind. And I think one question that we can use to start off this discussion is to deal with the problem of treatment resistance, which is something that is highly common when using psychotropic drugs. A review in Nature in 2021 pointed that around 20 to 60% of patients will experience treatment resistance. So the question that I would like to ask you is, what strategies or what can we do to deal with this situation?
I think the concept of treatment resistance is quite a complicated one. And today we are actually trying to move to steer a little bit away from this definition, because it can be seen as a little bit stigmatizing. It might make people a bit hopeless with regard to their condition and so on. Sometimes it's even associated with some blame that the patient might feel. with regard to that. It's useful for us to keep talking about treatment resistance, but at the same time, it doesn't tell us, because we use the same language, but then it doesn't tell us much about what we can do in this regard. The reasons why some people might not respond to treatments could be several. It could be that sometimes the disease is a particularly severe one. It could be, however, that the problem is that we're using maybe not the best medication for the specific patient at the best time. So in other words, what I'm saying is that we oftentimes like and need to consider psychiatric disorders in clusters, in categories. We talk about depression, but depression could mean a number of very different things. And the reasons behind somebody's depression might be, well, very different between one person and the other. And at the moment, we need to stick with what we know and what we have, and the treatment tends to be quite similar for all our patients. But hopefully, as we get more progress in and advances in science, and importantly, we'll be able to apply these progresses in our routine practice, then we will be able to say what specific patient might be responsive to at that specific time for their very particular illness. Mm-hmm. So rather than treatment resistance, maybe we need to start thinking about what specific disorder we need to treat. And in this context, the medications you were mentioning so far might indeed play a role. So a nice way to think about this is that of all people with depression, there might be a subset of people who have a very common form that respond to psychotherapy, and we know that lots of people do that. There are some very common other forms that respond to commonly prescribed antidepressants like SSRIs. Mm-hmm. But then there might be some people for whom the reasons behind their depression, let's say, might not have much to do with these mechanisms here. For example, one mechanism might be inflammation. And for these people, we need to think about giving drugs that have anti-inflammatory properties. Obviously, then there is also the more complicated bit, people for whom their depression or mental disorder in general might be explained by several causes at the same time. And that's where we need to smarten up and try combined approaches.
Yeah, no, I find that very interesting. I remember some years ago when I was researching depression, I found that, for example, depression, which is mostly characterized by anhedonia, doesn't tend to respond as well to SSRIs than depression, which is more characterized by anxiety, which I found it be very useful because at the time I thought that, depression is one thing. We discretize it. We define these boundaries about what depression is, and we think it's all the same, but it isn't. It's, like you said, it's a big spectrum of a condition.
That's very true, Joao. And the example of anhedonia is extremely pertinent, actually. Anhedonia is a symptom, is a common one. Not all people with depression will experience anhedonia, but some of them will. And in those in those where we find anhedonia, that's a particularly difficult symptom to treat that might actually benefit from alternative or at the very least integrated treatment approaches.
Yeah, no, and regarding that, of course, we know that conventional pharmacological treatments such as SSRIs, atypical antipsychotics, they play a very important role in treatment, but we know that they have some cardiometabolic issues with them, some side effects. And so sticking with the case of antipsychotics, because I think it's really relevant, because most people who are taking antipsychotics will need to take them for a long period of time. And we know that atypical antipsychotics may drive insulin resistance up, and that might be a problem because, as we know, insulin resistance seems to be associated with a wide array of mental disorders. And one of the mechanisms seems to be that antipsychotics may be modulating the function of the pancreas through D2 receptors. And so I think your work is very interesting because you're trying to repurpose other types of medications and finding ways to connect them with mental health, with mental disorders. So in that specific way, I wanted to ask you, what is the potential role of GLP-1 receptor agonists? So for most people, they might know it through Ozempic, the commercial name for semaglutide. But through your research, what role do you think these other medications can play?
Well, this is a very good question because the answer at the moment would be we don't know.
Mhm.
This is an area that is being really very actively explored. Obviously, these drugs have been around for quite a long time, actually, but in other fields that are not psychiatry.
Mhm.
They were initially designed for use in endocrinology, especially for type 2 diabetes, and more recently, they have known this real boom because of their very strong effects in obesity. However, these medications seem to affect a number of bodily mechanisms that might go well beyond these couple of conditions that are already very, very important, very prevalent: type 2 diabetes and obesity. So there are lots of work that are looking at the use of these medications for cardiovascular conditions that you were mentioning earlier, and these are being quite overwhelmingly positive, I'd say. They are looking at them in kidney conditions. They're looking at them in liver conditions and so on. For a number of years, they've also started looking at them for brain health, including neurological and psychiatric disorders.
Mhm.
And that the research area regarding psychiatric disorders is comparatively quite a bit more recent.
Mhm.
So we do have quite some growing evidence. Lots of it is coming from preclinical studies, so studies that are done in vitro or in animals, very difficult to then translate to clinical populations, to humans, to patients. So it's still a very, very open area, let's say, but definitely potential for a number of cognitive disorders. When I say cognitive disorder, in this case, I'm referring more specifically to dementia. Think about things like Alzheimer dementia, Parkinson, and so on. Probably a role in addictions, and then a few studies looking at them in psychosis, especially because of the reasons of antipsychotics that you were mentioning,
Mhm.
and more recently also mood and anxiety disorders. As far as I'm aware, these are the main avenues that people are looking at for GLP-1s at the moment. There might be more coming up. Eating disorders is obviously a quite maybe one that we take a little bit for granted, but we shouldn't really forget about it. But these are already plenty, so there is plenty to look at, plenty of research to do already for this area of psychiatry, I think.
Exactly. So the very interesting point is that it seems that the goal is to improve somewhat the metabolic health of the individual. And by improving the metabolic health, you can somewhat improve outcomes in all of these mental disorders. Do you have any opinion regarding the use of, for example, the ketogenic diet? I've seen some literature coming out
Yeah.
that it might have some potential use for bipolar disorder and maybe schizoaffective disorders as well. Do you think this is a potential also treatment outlet?
I'd like to say a couple of things on what you've just mentioned. So the first one is that it's very true that uh, it is possible that what we are seeing in terms of potential benefits of these drugs on mental health are secondary to their established metabolic benefits. Um, and that's because we know that there are lots of links between these conditions, between metabolic problems and psychiatric disorders. Um, However, one is also allowed to wonder whether there is a more direct effect that is going on, not necessarily related to metabolic disorders, which would be very interesting to explore, because it would mean that we might think about using these medications in people with psychiatric conditions, regardless of whether they have a clear-cut, comorbid, concomitant metabolic problem. Am I making sense?
Yes.
But I think that's definitely something that we still need to clarify. And for GLP-1s especially, lots of studies are ongoing. We do make a mention of some of them in a recent paper that was published on Nature Mental Health. But we definitely need much more, and this is something that will come in the next few years, I believe. Then you asked me specifically about ketogenic diet. I must confess I'm not an expert in that area. So please do take what I say with a pinch of salt. I don't like speculating or anything, but I am aware that ketogenic diet it's an interesting and quite established actually intervention for some disorders like epilepsy. There is lots of literature on the topic that is going on now for a while. So I think it's a quite robust area. Now, we've always known that there are connections between epilepsy and psychiatric disorders, which is interesting. And in fact, some of the medications we use in psychiatry, especially all our mood stabilizers, apart from lithium, which is a bit peculiar and is the best mood stabilizer, but they are anti-epileptics to start with, stuff like valproate or carbamazepine or lamotrigine. So there are definitely connections there. Now, ketogenic diet is quite established in epilepsy. There is now been lots of research being done in psychiatric disorders. I think you've mentioned schizoaffective disorder. I must confess I don't know about that. I know that there are some very active groups, especially for bipolar disorder here in the UK. I think they're getting some quite exciting results. I'm not one that likes making big claims on these kind of things. I think, to be honest, the evidence is still not quite there. But if I had to bet my money onto something, I think the evidence will probably come up once again in the next few years. But I'd like to emphasize, I couldn't recommend to people with psychiatric illnesses, whether bipolar, schizoaffective, or depression, to go on a ketogenic diet based only on what we know now.
Yeah, no, also my understanding is that it's still very early days, and we still need to really understand what the issue is, because I think one of the proposed mechanisms for the ketogenic diet is that it may help people who have high levels of insulin resistance, and so by reducing that, it may help their mental health as well. But I'm still not sure about the mechanisms behind that. So it's like you said, it's very early days. I do think something that could be very interesting is, as we now engineer new therapeutics to treat all of these mental disorders, to what extent do we actually need to develop compounds that cross the blood-brain barrier, instead of just also targeting more downstream targets? Because, and you can maybe make me understand this better, because for GLP-1, I know that there's some conflicting literature regarding whether it passes the blood-brain barrier, depending on what type it is. So I just wanted to know what you think about this issue.
Yeah, you ask very beautiful questions about these mechanistic aspects, and once again, I think the real issue is that we don't know exactly what is going on and what is needed for a medication to be effective in psychiatric disorders. In the sense that let me clarify this. It should make sense that if all mental disorders start from the brain, a medication needs to be able to reach the brain in order to have an effect on mental disorders. But we also know today that our body is, much more interconnected than maybe we thought once upon a time. The brain is not separated from the rest of the body, and our mind is still residing in there. if we believe that. I think we should. And going back to the way we really started this conversation, that we want to overcome this dichotomy between brain and mind, I would be surprised if lots of interventions that we do at a more peripheral level, so things that don't necessarily cross the blood-brain barrier, they wouldn't still be able to have some degree of effect on mental processes as well. Again, the extent of that, we don't know, and it could be very variable. Sometimes it could not be enough. But the brain is not an immune privileged organ, as we know today, or at least it is, but not as much as we thought once upon a time. There are several ways in which the immune system can also access the brain. More recently, I think you had mentioned it earlier, there has been lots of research about the gut-brain axis and all the microbiome and the effect that the microbiome can have on mental processes that we simply were not aware of until not too many years ago. Back when I was in medical school, we wouldn't really talk about that. So there is still lots that we need to find out. Now, how that applies to GLP-1s, that makes the whole conversation even more difficult, because we don't know exactly how well GLP-1s cross the blood-brain barrier. Most of the evidence we've got comes from animal studies. If you do a quick search of medical literature, you will find quite contrasting information, even if you go only on reputable journals. I was surprised about that myself when we published our previously mentioned paper. So there is clearly no consensus amongst scientists who have worked on this their whole life. So I don't feel like, I'm not going to be able to come here and challenge that. I think the best answer I can give is, seems like most GLP-1s can cross the blood-brain barrier at some point. I do wonder whether, even if they didn't, what they do so strongly at a peripheral level might still have an effect actually on mental processes anyway. But this is maybe a bit of a provocation that I'm going to leave there with you.
Yeah, no, for me it was interesting because I heard some literature say, and of course there are some compounds that may reach the brain without passing through the barrier. For example, if they enter through the circumventricular areas, which are, for those listening to us, midline brain regions around the third and fourth ventricle, and where the blood-brain barrier doesn't have as much as an authority. And also something that I wanted to ask you is, there's also this hypothesis about the leaky brain, where when we have high levels of inflammation associated also with mental disorders, this barrier becomes a little bit more permeable, and that to some extent is bad, but can that also provide us with more opportunities to treat the brain?
Yeah, that's another very, very interesting mechanism, Joao, and unfortunately complicates matters even further. If we haven't confused our listeners yet well enough, we can get them even more confused now, because as you're saying, I think there is pretty good evidence that in a lot of cognitive and mental disorders, think about dementias, think about depression and so on, there are some glitches, let's say, with the functioning of the blood-brain barrier. And very difficult, obviously, to observe and assess. It's not something we would be able to do in our routine clinical practice, but chances are that they are there. Evidence is showing that quite strongly. Now, that should mean that in certain people where there are these kind of dysfunctions, drugs that normally would not pass, or maybe would pass the blood-brain barrier at a slower and lower rate, they might do it at a faster and a higher rate. And then arguably, as brain function recovers, as basically they are getting out of the episode of illness, maybe that changes. And that means that maybe their treatment might be not as effective as it was initially, simply because they're getting better and that is getting fixed. That would be, as you can imagine, it would be extremely difficult to investigate. But I think there is something going on there, and it's something that we definitely need to be very aware when we are treating these disorders, and when we see a change in the way somebody responds to their treatment, maybe this mechanism might be implicated.
Yeah, no, it's definitely very interesting. I also wanted to ask you a question regarding your recent published paper. I'm just going to say the name. I'm going to link all of these papers we're discussing in the description. But the paper is titled "An Analysis on the Role of Glucagon-like Peptide-1 Receptor Agonists in Cognitive and Mental Disorders." And there's an observation there in your study which points that after GLP-1 administration, those with depression that is mostly characterized by anhedonia seem to have some worsening of their condition when compared to those who did not have anhedonia as one of the primary characteristics of their depression. Do we know something about why that might be the case?
I think that's a bit of a speculative statement that we do more. It's in. I think what you're referring to might be in the discussion.
Yes.
Apologies if it wasn't very clear. I think what we are trying to say is that if we think, as evidence seems to be showing, that GLP-1s might have a bit of a dampening effect of a number of reward processes, which might well explain why they're so efficacious and in fact effective in the treatment of obesity. They just reduce the reward. They might reduce the reward associated with food. Then you might imagine if we translate that to other forms of reward, and we gave these medications to some people who already have low reward, people with depression and anhedonia, maybe that could make it worse.
Okay,
The reality is that we don't know that. In fact, there is some preliminary evidence, so please do take that with a pinch of salt, that might be showing the opposite. It might be showing that actually that's not what is going on, but in fact there might be a recovery of these deficit in reward. And the mechanism behind that, we don't know that. We are actually doing a study in Oxford. It was recently completed, but we are still analyzing the data that is investigating these things exactly. But I think the best way I can think of to try and explain this is that these medications do something a bit more complicated than simply dampening the reward system. They probably are regulating it in a complicated fashion, in a way that maybe for people where the reward starts as lower, it brings it back to what we call homeostasis, back to the middle. For people where it is a bit too high, it brings it back to homeostasis, again, back to the middle. Again, this is something that we need to investigate further, but a sort of a regulatory mechanism for these medications is probably the one that makes the most sense. And I'm sorry if I continue on this, but one more thing to think about is that these medications are actually quite well established for having anti-inflammatory effects, and I think there is quite good evidence that anhedonia is a symptom that is particularly associated with inflammatory stimuli. So it could also be that maybe something is going on from a purely reward basis, in the sense that these medications might lower the reward sensitivity, but then at the same time, because of their anti-inflammatory effects in people who have this kind of problem, maybe these medications are improving that reward aspect. So the fine balance between these two things is the one that eventually will explain how a specific patient, a specific person will respond to this drug. I don't know whether it makes sense.
No, it does. No, it's absolutely fascinating, and it just shows once again the complexity and the number of systems that are involved. For example, in depression, right? Like historically, there has been the serotonin hypothesis, so everyone just talked about serotonin being implicated in depression. Then people started also discussing the role of glutamate. now also dopamine, especially in cases with anhedonia. No, I just find it absolutely fascinating how, and we will get this later on in the discussion, because I also wanted to ask you about schizophrenia, where sometimes when we improve one symptom, we might make another one worse, because all of these things seem to be interconnected, and by flipping a switch, something else turns on. Um, but before we do that, I also wanted to ask you about your work regarding statins. I also found it, um, highly interesting how statins, which normally are used to decrease LDL cholesterol, can potentially be useful for depression.
Yeah, no, thanks for that. I think we on statins we have been doing lots of work over the last several years, and there are some other major centers in continental Europe, in the States, in Australia that have done similar work. The rationale behind that is that, as you're saying, statins primarily work well. They were conceived to work on LDL cholesterol, but actually it seems like lots of their benefits can be accounted for by their anti-inflammatory action. They do have anti-inflammatory properties, and this seems to be particularly important in cardiovascular disease, especially in the sense of stabilizing atherosclerotic plaques and making them less likely to break. So definitely, and that's what causes myocardial infarction, a heart attack, basically. So that's definitely a very important mechanism, and we got lots of evidence of that. Because of that, they have drawn an interest into psychiatry too, because of the idea that inflammatory issues might be either at the root cause or a contributing factor to certain mental disorders. I must say, for statins specifically, results more recently have been a bit underwhelming. That has included studies we have conducted ourselves. Some have been published, some are coming up on publication, and also other studies that have been published more recently. I think there is a big study from London that was published a couple of years ago that is showing null results for statins in terms of depressive symptoms. That might well be the case. I think the way I see, after all these years of research on statins, the way I see their role for use in psychiatry would not be primarily to treat depression or mental health symptoms, but would have more to do with making sure that we are addressing the physical health needs of our patients quite holistically. And again, once again, thinking about a little bit beyond, are we treating the physical health aspects or the mental health aspect? We are just treating the health. We are just doing something hopefully beneficial for the health of the patient, regardless of whether it's physical or mental.
Yeah, no, I think another compound which has some mixed results, and you have done some research on it, is creatine monohydrate.
Yeah.
Particularly in depression. Some studies show positive effects while others show null effects. What is your opinion on the potential use of creatine monohydrate for those who are struggling with depression?
In a few words, it's exciting. It's, in a way, creatine is an old compound. It's been around for a very long time, but the research on it is very new, and obviously it opens up some very fascinating avenues with regards to the interaction between our energy levels, physical exercise, and mental conditions, such as, for example, once again, depression, that we know are characterized by lower degrees of activity. So it's all very promising, but in my view, we don't know enough. Lots of studies come from animals and animal models of depression. Once again, sorry for repeating myself, but difficult to translate to humans. So I think I personally am interested, but I would be very cautious. And particularly cautious because creatine is available over the counter. Anyone can go online and buy it, buy creatine. It's still a compound that can have significant side effects. So I would not recommend going off and start taking creatine to treat your own depression or whatever condition, because we simply don't know whether it does anything in this regard. But it is exciting.
Yeah, no, for sure. So in terms of some of these compounds we have discussed, and for most pharmacological drugs, I think there's a lot of misinformation going on online, which might happen because of some poor use of statistics. And so one of the main concerns that many people share with the use of SSRIs or other forms of psychotropic medications, or even with GLP-1 drugs, is the increased risk of suicidality. So people are claiming that there's a causal link between the use of these compounds and the actual outcome. The thing is that many people who start taking these drugs in the first place might already be at a higher risk of suicide. What is your view on this issue regarding this particular side effect and these medications?
Well, I agree it's a very important issue. The reasons are obvious. You are talking about an extremely tragic event, if that occurs, that in this specific case might have totally been preventable. But we need to be very cautious in passing any judgment, whether it is in favor or against the likelihood of these drugs to cause suicide, or indeed to have some positive, some beneficial effect on suicidality. We also need to be aware of our history if we want to learn something from the past. There was a quite famous medication. It's called Rimonabant. It was withdrawn from the market more than a decade ago now. It was an anti-obesity medication, so it shares some similarity with GLP-1s, but the mechanism of action was completely different. And it works on the cannabinoids, the endogenous cannabinoid system of our body, of which we know quite little about in a way, compared to, for example, serotonin or dopamine and so on. And that, as I mentioned, this drug was withdrawn from market after it had been approved and licensed and used, because there was this quite strong signal that it might increase suicidality. So quite a dramatic occurrence if you think about it. So we need to learn from that story. For GLP-1, there has been lots of concerns at the beginning because a similar signal was observed. Then, in my view, there have been several studies that have sort of disproved that, and regulatory bodies have their verdict has been that these medications do not seem associated with suicidality. One of the studies that hopefully contributed to that was also our own study published on Lancet Clinical Medicine last year. I can send you the link if it's helpful. And we observed no association for the use of this medication, semaglutide in particular, the GLP-1 semaglutide, compared to other antidiabetics in people with diabetes. Then there is another similar study that has been published on Nature Medicine that showed even a protective effect, potential against suicidality. I'm wary of that. I think suicidality is such a complex mechanism that before making claims that something reduces suicidality, I would be very cautious. Like, once again, I think the bottom line is that chances are these medications might not, they would not have a particular effect on suicidality, especially in people who did not experience suicidality beforehand. But we need to know more, as you were saying, for people who maybe are already suicidal because they might have an underlying psychiatric condition, such as depression, that might be a link to suicidality. Since the publication of these studies, because this has become a quite trendy topic, unfortunately, there have been lots of other studies that have raised this concern again. my observation is that the design of most of these studies they're not designed to show causality as in a way that is similar to the couple of studies I've already mentioned, but also they have a design that is less robust than these studies that have shown no effect. So I think they would have been very timely if published earlier on, when we didn't know what these medications were doing and we just needed to know, is there a signal or not? But now it's starting to become a bit, I'd say, less relevant. What we need to do is looking at data from robust data sets and data from randomized controlled trials. Indeed, there has been a post-hoc analysis published on a JAMA family journal, and again, that's a bit specific to people taking these drugs for diabetes and obesity and so on, but that's not showing any signal for suicide. So I find that quite reassuring. I don't know about you.
Yeah, no, for sure. I think it's a very important topic because there's a lot of stigma regarding using psychotropic medications. And so many people are suffering a lot and they refuse at all costs to, try some of these medications. And I'm not saying that everyone should take these medications, but
Yeah.
it is important that people do not make decisions based on wrong information. And unfortunately, there's a lot of stigma and a lot of fear mongering as well.
A lot of noise. I think there is also a lot of noise that doesn't.
Yes.
Yeah.
Yes, absolutely. A lot of noise. So, I think it is very important to, like you said, have a cautious approach, but at the same time, be open-minded with the data and being focused on data-driven insights. And related to that, I wanted to ask you, because psychiatry to some extent is a unique field in medicine, because if we compare it with, for example, neurology, where in neurology, for most conditions, we can look at an image of the brain and pinpoint that there's the perpetrator. In psychiatry, we can't really do that. We know that there are some neuroanatomical changes in the brain for a wide array of disorders, but it seems that we don't really have as much as concrete biomarkers in psychiatry than we do for other fields of medicine. To what extent do you think that now with AI and new methods of, data mining and research, to what extent can that improve our outcomes in psychiatry?
I think, well, what you're saying is what makes psychiatry so fascinating, at the very least for me, right? The fact that there is still quite a little bit of unknown, or maybe it's just a bit more difficult to discover. I'm with you on this. I think as we become capable of using more sophisticated methods, also exploiting AI and so on to investigate biomarkers and to try and disentangle psychiatric disorders at a finer level, that will provide some very useful insights. And I think if that helps us actually overcoming that issue that we were mentioning earlier of thinking all depressions are the same, all schizophrenia are the same, all bipolar disorders are the same, that is really what is going to make a difference for the treatment of our patients, rather than necessarily discovering new treatments. I know it sounds less exciting, but I think we need to maybe a bit of a shift towards finding the right treatment for the right person might be better than simply trialing new things that then might not show a positive signal in trials simply because we are giving them to the wrong subset of people. So there is this aspect here. The other aspect is one instead that I would maybe challenge you a bit, in the sense that I agree that for a lot, probably most medical specialties, we do have some quite clear-cut biomarkers that help us with our diagnosis and with our treatment to stay in the ballpark of diabetes and GLP-1, since we've talked about it so far. When we measure HbA1c for diabetes, we use that for to help us with making a diagnosis of diabetes and also to monitor our treatment. That's quite clear cut, that's quite clean, that's quite tidy, and we like to use that. But I also think that there is much more to these diseases in terms of mental processes as well, that actually is maybe sometimes even neglected, sometimes simply a bit forgotten. But back in the days, it was actually a key aspect of the treatment of these patients. So I think there is much to discover also in these other branches of medicine, and in the same way that psychiatry can learn an awful lot from these other areas of medicine in terms of measurable biomarkers such as blood biomarkers and so on. I think the rest of medicine might also benefit and being informed from what we do in psychiatry in terms of behavioral biomarkers, and hopefully with the help of AI we will be able to integrate these aspects together and have a bit of a fuller picture regardless of whether we are treating a psychiatric disorder or another medical condition.
No, of course. No, I think regarding that, I also wanted to ask you that what is it now in the field of psychiatry that you identify as being the greatest obstacle to overcome? It can be in terms of disorders or the understanding of particular mechanisms. What would you consider to be one of the biggest challenges right now? I think a lot of people would perhaps point to psychotic spectrum disorders, where there seems to be a greater difficulty in treating these types of disorders than, for example, mood disorders like depression. Of course, it depends on a case by case. It's not wise to apply a general rule to all of this. But what do you think makes certain disorders harder to treat than others?
I'm going to give you a slightly banal answer to this, but I feel like I have to, because this is what I believe in. What I believe in is simply is much more simple. Is lack of resources.
Okay.
I think we do have. There is a bit of a running theme that in psychiatry we don't have treatments that are as efficacious as in other specialties, that we don't know enough in terms of mechanism, of causes, and so on and so forth. I can't fully agree with that. I think psychiatry as a medical specialty is extremely rich, but we really struggle to learn and to apply that wealth of resources that actually might be there for psychiatry. So just to give you an example, brain imaging has not made an impact in clinical psychiatry. We don't. I can't remember what was the last time that I had to ask for a scan in my clinical practice. In general adult psychiatry, it's slightly different if you are working in neuropsychiatry and so on, but in general adult psychiatry, that's really a quite uncommon procedure. And still there is a plethora of research studies that is actually showing some quite interesting findings in this regard. Again, I think some of these findings get a little bit confused and mixed up when we think about a psychiatric disorder as the same umbrella term for everyone, so results get diluted. That's probably impairing the picking up this kind of assessments and intervention in clinical psychiatry. But I think there is also a little bit of resistance in the sense that we just, for whatever reasons, people's own agendas or whatever, we just don't really apply very much what we already know. And that's, just to be clear, not only from what maybe would brand as the biological aspects of psychiatry, there is also all the social aspects, for example, that we know are extremely important in psychiatry, as in any other specialty. Social aspects of diabetes are extremely relevant, and I would challenge anyone who says something against it. But we simply don't do enough in this regard, and that I think it's because of lack of resources.
No, absolutely. I fully agree. And Yeah, related to that, you know, with normally now we struggle with this idea of the replication crisis, where we have some difficulties in sometimes replicating findings from past studies. What is in your opinion something that we can do better in scientific research, particularly maybe in the field of psychiatry? What can we do better here?
With regards to replication, you
Exactly. With it can be study design or even the statistical methods used from a
yeah.
statistical literacy standpoint, or even from a scientific
Yeah.
communication view.
Um, I'm unusually optimistic in
Mhm.
this area. I think there are some very positive steps that people have been taking over the last few years, at least. First of all, the recognition of a problem that has been ongoing for decades. And actually, only now we are talking about that. That's a great starting point, acknowledging we have an issue with that. I think following principles of open science is something that is being actively promoted by major academic institutions and hopefully industry as well. So knowing, having lots of detail about the methods that somebody uses, changes that have been made to their protocols, to their methods en route. So that's been very useful already. I think then the next step is got to do with the availability and dissemination of these findings, including negative findings, that very much depends on journals and publishing companies. And I think there is something moving um, in a positive direction with that too. So as I said, yeah, again, I'm quite optimistic. We are doing the right things,
Mhm.
and obviously we can always do better. But the results of these positive steps that are being taken now, we will only see them uh, 5 to 10 years from now. Now we are still seeing the result of maybe decades and decades of research done in a different way.
No, yeah, I fully agree. Yeah, I think guidelines overall, having to share your data set, what you used, the detail in the methodology, I think all of that has definitely improved a lot. And like you, I also share a very optimistic perspective, especially because these days, along the mainstream consensus, there is, I think, a growing science denial, which is extremely hurtful because people criticize science without knowing what science is and how hard it is to do science. So I think this is a very important conversation, because science is something that has given us a lot of the things we cherish. So keeping this in mind, I think, is also extremely useful. And as a last question, because I don't want to take much more of your time, I wanted to ask you, as a psychiatrist, what do you think are some general practices that, in your opinion, are essential for mental health?
General practices.
Yeah, so general advices for people who want to improve their mental health. I know this is can be a hard question because it really depends on individual to individual, but what do you think are some, science-based techniques or practices that people can use to promote and improve their own mental health?
I think the first step, really, which lots of people might be taking for granted, but it shouldn't, is if you think you need help, go and seek help. Um, Overcoming the stigma around mental illness is definitely an essential first step in this regard. Um, the other side of the coin, on which about which I feel quite strongly, is then um, don't feel like it's a failure if you don't get what some people would call a label, so a diagnosis or something. Sometimes some processes that might feel deeply uncomfortable and even pathological, they may not be. And if those have been investigated properly and thoroughly with your medics, with your GP, with your psychiatrist, and so on, and the conclusion is actually there is nothing wrong, that's good news, and we should
Yeah.
be able to receive that too. So I think having a bit of a shift from these two extremes of not seeking help at all and not feeling like any help is given if the result is actually there is no psychiatric diagnosis here. I think is an essential key step. Thinking about some other practical aspects, I think some, again, slightly trivial advice that, however, we don't shy away giving it in any other branch of medicine. So things such as good diet, physical exercise, and so on. That's the first advice you get when you go and visit your cardiologist.
Yeah.
That's the first piece of advice you get when you go and visit your endocrinologist. I think in psychiatry we shouldn't be shying away from giving that piece of advice too. If your condition requires more complicated treatment, whether it is psychological talking therapies or medications, or indeed a combination of both, I think you should know that treatments work. And that's maybe the take-home message I want to give, against maybe a sort of widespread pessimism with regards to mental disorders being incurable. I disagree. I don't think that's true. We got lots of very useful treatments and lots of people that find them life-changing. So there is lots of hope there. Just go and look for help when you feel like you need it.
Awesome. No, I think that's a wonderful message, and I think also a take-home message for our listeners is that in order to understand the brain, we also need to look at the body, and vice versa. Everything is. I really enjoy the concept of embodied cognition because of that, because you need to take into account the full system, the full organism. And once again, Dr. Riccardo, I wanted to thank you so much for accepting this invitation, and it was a pleasure talking to you. Thank you very much.
It's been a real pleasure for me too.
Thank you.